Hey guys, it's Dr. Sarah here. Today on the She Found Motherhood podcast, Alicia and I are talking about the top 5 reasons people have cesarean births. Cesarean section is a common surgery and often life-saving. Approximately 30% or 1 in 3 pregnant people will give birth via cesarean section. So we think it's really important to talk about and to have an understanding going into your childbirth experience. We think it's so important, in fact, that we spend a lot of time talking about what to expect about a cesarean birth in our Pregnancy to Parenthood Masterclass. If you haven't checked that out, head to the link in our bio and you can learn more about it. We'll get into this important topic right after this quick message. Welcome to the She Found Motherhood podcast. We are Doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it. Hey everybody, it's Dr. Sarah and Alicia here. We are talking today about the top 5 reasons for cesarean sections. We are so excited to talk about this topic. It's Alicia here, and I am very passionate about this because my second was born via emergency cesarean section, and to be honest, without that medical intervention, there is a very good likelihood that I would not be here today.
Every time you say that, I tear up.
Right. Well, it's true,
I
right?
know.
And it's something you try not to think about. But anyway, cesarean sections certainly have a place and are an amazing intervention if we need them. And unfortunately, these days on social media, there is so much negative rhetoric around birth interventions. And so we just want to say we recognize that all interventions are not good interventions, but for those people who need interventions, they can be life-saving, both for you and or your baby. We just want to make sure that people have a really good understanding of what cesarean sections are and why people might actually get one. So about half of cesarean sections are planned or what we call elective, and about half are unplanned or emergency. And to give you a context of how common they are, about 1 in 3 pregnant people have a cesarean section. So the rates are about 28 to 30% of cesarean section rates of all births. And this varies by province, it varies by community, it varies by country even. And there's many reasons that I don't think we're going to get into today around that, but certainly
it's like
a whole other podcast. Certainly about 1/3 of births, babies are delivered by cesarean section. We'll start off with elective cesarean sections. And so elective are ones that are planned. So they're planned. You're going into your birth experience knowing that you're going to have a cesarean section versus unplanned or emergency. You're going in expecting or hoping for a vaginal. And then for whatever reason, we'll talk about the reasons later, you have a cesarean section. So for elective or planned cesarean section, most of these, about half, are actually repeat cesarean sections. So somebody has had a cesarean section in their previous delivery for one of the reasons we'll talk about, and they choose to or are advised to, and ultimately choose to, have a repeat cesarean section. So now many people can actually try for a vaginal birth if they want, or try for a labor after cesarean section. This is a TOLAC. And if you actually choose people who are good candidates, they actually have 60 to 80% success rate of having a vaginal birth after cesarean section. So certainly if you had a previous cesarean section and you've not been told that it would be ill-advised to try for a TOLAC, have a conversation with your care provider to understand, why you might choose to try or why it might be advised that you don't. But certainly if that's something that you really want to have a conversation with, have a conversation, have it early, have it frequently, so you can really understand what your options are.
Yeah.
So a few reasons if you've had a previous cesarean section, you may be advised not to have another cesarean section is if the scar on your uterus is up and down as opposed to side to side. And this is because as our uterus, the top of our uterus grows first, and so it's quite thin, versus the bottom of our uterus it's thicker and generally a little bit more secure. And the way the muscle fibers run, the cesarean section scar is less likely to open up versus one that's up and down. There's a very high risk that if your uterus starts contracting, that muscle starts contracting, the scar can't actually hold it in place, and so it will open up, which is very dangerous for both you and for your baby. So an up and down cesarean section scar on your uterus, we do not recommend
No.
trying a vaginal delivery or even laboring at all.
And now, if you did have that type of scar, you absolutely should have been told. They're very uncommon. Typically, the most common reason I would think they're done for is preterm. So if you had a preterm, very preterm cesarean birth, it's always just good to double check because the scar on your uterus doesn't necessarily match the scar on your belly. So most incisions through the skin are done through that horizontal, but it may be a vertical on your abdomen. So you can always just check with your provider, get a copy of your operative note. Your provider should absolutely know this.
Exactly. Yeah.
Other reasons for elective cesarean sections include, in the same vein, a previous surgery on your uterus that makes it dangerous to labor. So the most common surgery and reason for this would be a particular type of fibroid surgery that cuts through the muscle of your uterus. Now, the medical term for this surgery is called a myomectomy, and that is when you have a fibroid. So a fibroid is, my coin is an abnormal growth of normal tissue. So it's basically just an abnormal growth, in this case, of the tissues that form the muscle wall of the uterus. And this can impact fertility, can also cause really heavy periods, significant cramping. And so a lot of folks choose to get them removed. And if this removal of this type is done through a myomectomy, it does take a full thickness cut through that upper part of the uterus. So it's the same reasons that we would not recommend someone trying to labor who's had that vertical incision, the up and down incision, is that the integrity of the scar and the muscle fibers, just the way the scar is healed, it's just very likely to rupture during labor, which would be very unsafe. Now, we chatted about this on a live we did not so long ago with Jeanette, Ask Jeanette. And one thing that Alicia noted that I think is important to understand is that not all fibroid surgeries would be like a contraindication or a reason not to have a trial of labor. So some fibroids grow on the inside layer, so in the endometrial lining, or on the very, very outside, just under the mucosal tissue. So just because you've had a fibroid surgery, that does not absolutely mean you can't have a trial of labor. It's important to understand the type of surgery that you had, and your provider should absolutely be able to find that information out if you don't have it. Another medical reason for elective cesarean section is the location of your placenta. So if you have not listened, we're going to recommend you head on over and listen to our podcast about Placenta Previa. We'll link it in the show notes below. But just generally speaking, Placenta Previa, or low-lying placenta, is when your placenta sits on the bottom of your uterus over the cervix, which is the opening from your uterus into your vagina, or very close. And the risk of laboring with that is just significant blood, which we absolutely advise against. That would be another common reason for elective surgery. And if you want to learn more about Placenta Previa, we'll link that podcast below. Probably one of the most important reasons I think that is undervalued is maternal choice for an elective cesarean section. For whatever reason, it may be a history of trauma, it may be, severe pain. A lot of people have significant, vulvodynia or other vaginismus, and just do not want to trial a vaginal labor. That's your choice. And that choice should be available to every pregnant person in Canada, in North America. And so if this is something that you're considering, it's absolutely a valid choice. And we would recommend you chat with your provider and have a really detailed conversation with an obstetrician, an individual who would perform that surgery. Lastly, for elective cesarean sections, fetal malposition. So meaning that your baby is not head down. And so the most common malposition would be breech, meaning feet or bum down, or sometimes transverse or unstable lie, just meaning that they're lying. Believe it or not, some babies can lie side to side in your uterus, which seems crazy. Or they can just be flip-flopping all over the place. So that's another conversation. Yes, some centers do offer breech deliveries, and that's a very nuanced conversation, and we really should do a podcast on that. We will eventually. And I did say that was lastly, but there's one other reason, and that would be if you have a history of genital herpes, and if you have an active outbreak, it's recommended against vaginal birth. And the reason being is that there's a lot of viral shedding that can happen, and that virus can unfortunately infect your newborn. And it does not just cause, the sores that we typically see on mucosal surfaces like your lips or your vagina, but it can cause an infection in the brain. So if you have a history of genital herpes, it's really important to let your provider know, as we often will give people medication to try and prevent an outbreak at 36 weeks. And so those are sort of the most common reasons for elective planned cesarean birth.
So that's kind of elective, and now we'll talk about emergency or unplanned. Now, when we say emergency, most of the time cesarean sections are not truly happening in a medically emergent time frame. So every once in a while, there will be a decision to make have a cesarean section, and that baby needs to be out within the next 10, 15 minutes. That's truly an emergency cesarean section. Most there is time, whether it's 30 minutes or an hour, to have conversations, to talk about what the options are, to talk about what's going on, to see how baby tolerates things. And so we say emergency, and by emergency, we just mean unplanned. So it's not usually a running to the operating room, putting you asleep, getting your baby out as fast as humanly possible because we're worried that they're going to do horribly badly if we don't do it at that exact moment. So just keeping in mind, we say emergency, but we mean unplanned. So there's kind of two major reasons that we would have an unplanned, i.e. you're going in planning for a vaginal birth and you end up with a cesarean section. The first is what we term non-reassuring fetal heart rate. So listening to baby's heart rate is really one of the very few ways that we actually can tell how baby is doing in labor and how baby is tolerating labor. So a normal heart rate is between 110 to 160 beats per minute. It varies up and down by about 10 beats per minute over time. When your baby gets excited, we have what's called accelerations. They go up about 20 beats and last for at least 20 seconds. If your baby gets stressed out, though, we can see deceleration, so a drop in the baby's heart rate. These can be, the worrisome ones are often when they're happening right after contractions or when they're very long. So a deceleration down to 50 or 60 beats per minute, lasting for 3, 5, 10 minutes.
Not ideal.
It's not ideal because this is how your baby gets their oxygen. And we all need oxygen in our bodies to do well. Our brains need oxygen. Our organs need oxygen. When we say a non-reassuring fetal heart rate, it means that there's some kind of pattern that leads us to believe that your baby may not be tolerating labor. And what that means is whenever you have a contraction, the blood flow to the uterus is cut off, or blood flow to the placenta is cut off during that time of contraction. And then the contraction goes away and the blood starts flowing again. And our babies are meant to be able to cope with this if they're otherwise totally fine. There's nothing else going on. But sometimes there's other things going on that we may or may not know about. So if you're post dates, your placenta just doesn't quite function as well as it would if you were 38 weeks. They're only meant to last about 40, maybe 42 weeks. And so sometimes if you're post dates, that placenta just doesn't have the same ability to get the blood flow to your baby as quickly once that uterus decreases their contractions. Also, sometimes if your baby is really little, so preterm or very small, like intrauterine growth restriction, they just don't have the same capacity to deal with stress as a quote unquote full-term baby does, or a quote unquote normal sized baby does. And so they may not tolerate those repeated decreases in blood flow that normal labor does. Also, sometimes if your baby has some medical issue that we know about or don't know about, again, they may not tolerate the quote unquote normal labor, the normal kind of stopping of blood flow and restarting it every 3 to 5 minutes that a baby who is otherwise healthy would. So there's a variety of reasons where we might see a baby not tolerating labor. And so that would be what we call non-reassuring fetal heart rate. And if you're not very close to delivery, then oftentimes if we're seeing those patterns of your baby not tolerating labor, we'll either try to expedite delivery if we're able to, via the vagina through forceps or a vacuum. But if you're not even close to that point, that's when we would recommend a cesarean section. Another thing that can cause non-reassuring fetal heart rate is when you have an infection in your uterus. That causes the heart rate to go up quite high. It often causes your heart rate to go up. Sometimes you have a fever. And babies don't cope well with infections. And so if we see signs of that and you're not close to delivery, then we would recommend a cesarean section as well. So that kind of non-reassuring fetal heart rate is a term that encompasses quite a few things, but generally it's your baby is not going to tolerate the labor for however long we anticipate it to need to have a vaginal delivery. And so that's when we would recommend a cesarean section.
Now, the other most common reason for emergency or urgent unplanned is often called, and we both hate this term, failure to progress. The other medical word for this is called dystocia, meaning stalled or, non-progressing labor. And so we really need to start changing our language because, it's just disheartening. Right?
Totally.
And so what this means is that despite what we believe to be adequately strong contractions, that your cervix is not dilating or your baby is not coming down the birth canal. So when we look at dystocia or failure to progress, there's generally 3 factors that play into this. And when we're learning about birthing and obstetrics in our training, we learn about the 3 Ps: power, passage, and passenger. And we can look at each of them all separately to understand what may be happening. So first things first is power. So power refers to the strength of your contractions or your pushing effort. So sometimes, for whatever reason, our uterus just does not perform as strongly as we hope. And the contractions are not very strong, not very frequent, or not lasting very long. So what we need is strong contractions that come regularly and last, at least 45 seconds or so. And, typically speaking, in addition to having nice, long, strong contractions, the harder we push and the more frequent we have contractions, the better the result. So if we're determining that it's a power issue, so generally speaking, meaning that your contractions are not coming frequently enough, they're not lasting long enough, or they're not strong enough, and this can be measured through a specific device that goes into your uterus, then we can opt to try and improve the strength or frequency of contractions by either breaking the waters if your water hasn't broken already, or by helping with offering some oxytocin medicine through the intravenous.
Now, just one thing about power is, there's always this talk about contractions every 3 to 5 minutes, lasting for a minute. But the most important thing that we measure is your cervix dilating.
Changing. Yes.
Is your baby coming down? So if you're having a contraction every 10 minutes, but things are progressing, that's great. You've got enough power.
Totally.
And so it's a bit of it's a challenging one to kind of discuss because, everybody's told every 3 to 5 minutes, lasting for a minute. But really, how are you progressing in labor? What is your body doing? Does it need a little bit of help to improve its power? Or is that contraction pattern totally fine because things are changing?
Yeah.
Great. We don't need to do anything then.
Yeah,
because
exactly.
you are moving your baby down. You are dilating your cervix.
Yeah, exactly. Honestly, most providers do not want to intervene if we don't have to.
Correct.
So the next P would be passage. So this refers to the birth canal or the pelvis. And this runs through an intricate muscle system and bony structure. So some of our pelvises are shaped in a way that actually does not allow a baby to pass. And unfortunately, there's just no way that we can change or modify that. Our muscles and our tissues can stretch, or we can cut an episiotomy, which is very rare but can happen. But unfortunately, we cannot break a pelvis to get your baby out. And now, unfortunately, we're not trying to sound morbid or, fear-mongering, but before the advent of cesarean births, people whose pelvis shape would not allow a baby out would actually obstruct and die during labor along with their baby. And so this would actually stop that trait from being passed down onto their offspring. But now, because we have the opportunity to intervene and have cesarean births, this is no longer the case. For example, if your mother and your sister and your aunties all had cesarean births, then chances are it's more than likely a pelvic shape. And it could be that you inherited your father's pelvis, but it could be that you inherited your mother. So that it could be that you have that same pelvis shape. And unfortunately, we generally don't know this until you're in labor, unless you've seen an obstetrician. And every once in a while, we can do an exam and just tell by the feel of the pelvis. But this, unfortunately, doesn't often declare itself until labor.
And then sometimes your pelvis may not have the right shape to birth a term baby that's 8.5 pounds.
Yeah.
But if you have a preterm baby at 4 or 5 pounds, it may be quote unquote adequate enough for that. And, we can't say that your shape doesn't allow you to birth because if your baby is 3 pounds smaller, it may be fine. But if you go to term the next pregnancy, it may not allow that baby down. And so it's a tricky one as well. It's all a little tricky.
I know, it's also nuanced. We don't have a crystal ball.
No.
If only.
And the last, but certainly the not least, and often the cutest P is the passenger. And so when we say passenger, we mean your baby. So there's a few reasons why your baby may not be helping you out in the birth process. So the first is their position. So ideally, your baby appears the smallest to your pelvis, and they do this when they're in the OA or occiput anterior position. So the occiput is the back of their skull, and the anterior direction is towards your front. So when the baby is looking in the direction of your bum and has its chin tucked nicely to its chest, this is the ideal position. A baby in the OP or occiput posterior position is looking towards your belly. And this makes them seem, most of us say about a pound bigger to your pelvis. So that's a significant size. A 7-pound baby to an 8-pound
Oh, yeah.
baby. That's a
Dramatic.
significant difference in size. And then the third position that we often see is when they're looking sideways. This is the OT position. And unless your baby is very small, very few babies come out in the OT position. So I like to use the sweater analogy.
I love this.
And again, we use this with Ask Jeanette when we did the live with her. If you're thinking about you have a sweater that has a very small neck hole, when you put it on, you're putting it on the top back of your head because that's the smallest presentation. That's the smallest diameter or circumference of your head. And then you stretch it over the rest of your head. If you try to look up and put it over your face, there's no way you're going to get that on. And it's going to be super uncomfortable. I'm making the motions as we do it. And so the same thing applies to your baby. If your baby's not in an ideal position, sometimes if you're fully dilated, we can actually help you out with that. We can kind of push baby up. It's not the most comfortable things, but we can push baby up and we can help rotate baby into a better position and then hope that they stay. Some babies don't rotate. And again, sometimes it's because there's a cord in a weird spot and it's preventing your baby from coming down properly. Or perhaps it's your pelvic shape that just doesn't allow your baby to get into the right position. So we can try to help that. Again, trying to aim for a vaginal birth if that's what you're hoping, but it doesn't always work. And then the other thing we've kind of alluded to this, your passenger is the passenger size. So, some babies that are birthed at term are 9.5 pounds. Some are 6.5 pounds. For most people, birthing a 6.5 pound baby, especially your first time, is going to be much easier than a 9.5 pound. Now, not to say that people can't birth 9.5 pounds babies with their first babies. People do it, but not everybody has the pelvic capacity to do that. And, your baby's size also has a position there. But certainly, if you have a 9.5 pound baby and every person in your family, every birther in your family has pushed out 9.5 pound babies, then there's a much higher likelihood that you're probably going to be okay pushing out a 9.5 pound baby than somebody who's had cesarean sections in all of their family for 6.5 pound babies because they didn't fit. So,
it's interesting. Let's turn it over to me. No, is that my mom, I was OP and I had an OP baby, little bugger, which means looking up, sunny side up. So clearly our pelvis shape can allow for an OP baby to come through.
I went into labor with an OP baby, and then he so kindly rotated.
Good job, Wyatt.
He's such a lovely child, that Wyatt.
Yeah.
Into a wonderful position to birth an OA baby.
Too. Yeah,
Evie was born on April Fool's Day, and we called him the little tricker. So I had an emergency cesarean section with Evie. Yeah.
You just never know, right?
You just never know.
Okay, so let's recap because we talked about a lot here. So number one thing is about 30% of pregnant folks will give birth by cesarean. So that's about 1 in 3. So if you have 2 friends that are pregnant, chances are at least one of you is going to have a cesarean birth. Of those cesarean births, about 50% are elective or planned, and that can be primary, meaning your first birth, or a repeat, elective planned, because you've had a previous cesarean birth. And 50% are unplanned or emergency.
And those are generally for one of 2 reasons. Either the baby is not tolerating labor, so a non-reassuring fetal heart rate, or there's something to do with your fit of you and your baby and how strong your uterus is that leads to dystocia. And despite your provider's best efforts and the system's best efforts to help improve that, that fit doesn't work.
Yeah. Now, if you guys want to learn a bit more about, preparing for a potential cesarean birth, we would invite you to check out our online Pregnancy to Parenthood Masterclass. Alicia and I feel really strongly about coming into birth with all the information you need to make informed choice decisions in the moment. And so we spend time talking about this. And, we even do a tour of what an operating room looks like, just so that you can sort of visualize and make decisions and feel empowered and confident, even when you're, sort of in distress or under a time crunch. So you can head on over to our website. We'll link it in the show notes below. We really feel strongly about having an educated and empowered birth.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.